Hello, everybody, and welcome to our weekly COVID-19 provider update. This is Dr. Preble. I'm joined by Dr. Rachel Lanasa and Dr. Dan Anderson with infectious diseases. Just a couple housekeeping things, because this is the first time that we're using this Microsoft Live webinar format, but I'm glad to see that you're able to log in if you're listening to me right now. We will be taking comments and questions via the chat feature, which is on the right sidebar. There's two little dialog boxes, one with purple with a question mark. If you click on that, you can type in a question. We're going to wait to answer the questions until after the presentation is done. You might not see your question pop up, but I can see it on the background. And then any questions that we don't get to, we're going to try to put into a frequently asked questions document that will be sent out with a link to the recording of this presentation as well. The goal is this for this webinar is to be weekly on Fridays to try to get your questions answered and then also to educate as to the evidence-based medicine that's come out in the last week, as well as changes to AllinaHealth protocols. Just to put this out there, there's no HIPAA protected information being presented, but some of these protocols are specific to AllinaHealth if you're not an Allina employee. With that, I'm going to hand it over to Dr. Lanasa and we'll get started.
All right. Hello, everybody. My name is Rachel and I'm one of the infectious diseases doctors here at Abbott. So we'll get started. So things we're going to talk about today, we'll kind of go through the current epidemiology. I'll go over kind of just a brief COVID-19 overview. We'll go through a case. We're going to talk about testing and kind of the value of some prognostic labs. We'll talk about treatment. We're going to mention early persons under investigation, isolation, discontinuation, which is a new protocol that came out this past week. And then we're going to talk a little bit about transmission of the coronavirus and PPE, because I know that's kind of a burning issue on a lot of people's minds right now. So right now in the United States, unfortunately, we have the most COVID cases in the world right now. And as you can see, we're definitely on the steep part of the epi curve here. In the United States, as of this morning, there have been 82,000 cases. 10,000 of those have been hospitalized, and we have about 1,000 deaths so far. Most of these cases are on the coast, particularly in New York City. In Minnesota, as of yesterday, we had 346 documented cases through the Minnesota Department of Health, and that is out of about 13,000 tests, and so that gives us about a 2.7 positivity rate. There have been 2 reported deaths in the state, and on the right you can see our epi curve certainly, picking up, but not as steep as the United States. Not anything close to New York City. As I'm sure everybody heard, Governor Walz gave out the proclamation to shelter in place, which I believe is going to affect tonight at midnight. Although it is notable that Minnesota was found to be actually doing a pretty good job as far as social distancing. This tech company looked at GPS data before and after the social distancing had been initiated and found, looking at the difference in kind of distance that the GPS had traveled. And Minnesota had a marked change in average distance travel, 46%. So we got an A. So even prior to the stay-at-home proclamation, it seems that we were doing pretty well. So that is hopeful as far as kind of hoping that we'll be really able to flatten the curve here. So at Allina, as of this morning, we have 11 positive tests, 204 negative tests, 474 pending tests, which is something I'll talk about a little later. As far as our inpatient positives throughout Allina, so we have currently 1 non-ICU patient that's positive, 1 ICU patient, and then we've got many more PUIs, so 138 non-ICU PUIs, and then 15 in the ICU. So I'll just kind of go over a quick review of COVID-19 and kind of its presentation and what exactly the spectrum of diseases. For more detail, you can go look at my webinar from last week, which is available on YouTube. I go a little more in depth. But as far as kind of common presenting symptoms, kind of your common influenza-like illness. And so cough, fever, myalgias, GI distress, so diarrhea is a common complaint, as is nausea, vomiting. I know this is difficult because we're still at the time of the year where we're seeing flu and we're seeing some other kind of non-COVID influenza-like illnesses. So these are very common symptoms that you see, right? Some things that are coming out, we're getting a signal. I don't think we actually have hard data on it, but something that kind of sets COVID apart is that some patients are reporting anosmia or hypojusia, which are kind of, very kind of odd symptoms that might kind of point you towards possible COVID. So something that's interesting. Most people are just going to have a mild illness. So 80% of people will kind of just have an influenza-like illness that will pass and they'll do just fine. However, about 20% of patients will have a relatively severe illness, pretty severe with ARDS. And as far as the mortality worldwide, so it's estimated about 3.7%. Using the data from the CDC right now, it seems that in the United States, about 1.4, mortality rate is about 1.4%. Risk factors for severe disease and mortality seems to be cardiovascular disease, diabetes, lung disease, cancer, and really age. Most of the severe cases and deaths we're seeing are in the elderly. And so right now, there's still a lot of investigation into exactly how this disease progresses. But right now, the kind of leading theory is that initially there's this kind of replicative phase where patients will have fever, kind of your typical influenza-like illness, kind of / URI symptoms, versus potentially we're thinking that there is a cohort that is actually relatively asymptomatic. So this kind of initial stage. And then it's the second stage that is the issue that we're seeing. And so either patients are clearing the infection with their adaptive immunity, or what we're seeing is kind of this excessive pathologic response, which seems to be happening in about the second week of illness. We're really seeing this kind of cytokine storm, almost like a kind of virally mediated secondary HLH. And the primary pathology that we're seeing is really ARDS and multi-organ failure. And that is indeed the leading cause of mortality amongst patients. So we're going to go through a case. So a 41-year-old patient comes in who doesn't have any past medical history that he is aware of, but does not doctor frequently, is admitted with cough, malaise, fevers, and diarrhea, which have been going on for about a week. No notable travel. He does work at a restaurant, so he has been exposed to large groups of people. Upon presentation, was febrile to 101.8 with a normal blood pressure, was a bit tachycardic at the heart rate of 113, and was satting about 90% on room air. On exam, it was noted that his chest was diminished throughout. As far as his labs go, creatinine 0.85, sodium 133, AST slightly elevated at 71, LDH elevated at 316. White count normal, however, his absolute lymphocytes were low at 0.7, CRP elevated at 11.8, and ferritin elevated at 4,500. We'll go through his imaging. So this is the chest X-ray. So we had a scalp film off of the CT, and kind of, as you can see, he kind of has these kind of diffuse bilateral interstitial infiltrates. And then here's the CT, which if you listen to my webinar from last week, we kind of go through common CT findings, but this is kind of very classic for what we're seeing in COVID-19, kind of these ground glass opacities that are kind of multifocal, and you do see a fair amount of them kind of along the periphery, so kind of very classic CT for COVID-19 from what's kind of emerging worldwide. So upon admission, the patient had an MP swab sent for COVID-19. Influenza was negative. He was started on empiric ceftriaxithromycin and initially required about 4 liters of supplemental oxygen. However, throughout the next 24 hours, oxygen requirements markedly increased, and he was intubated in the hospital day 2 and did require low-dose norepinephrine. And then on hospital day 3, we get this COVID-19 PCR is positive. So at that point, he is started on hydroxychloroquine, and ID is consulted. He started on hydroxychloroquine. Unfortunately, the patient has progressed since then with ARDS requiring paralytics, proning, Flolan, and is still in the hospital. And so that's just kind of one, severe case that I wanted to go through to kind of show people kind of the spectrum of disease and then what is happening with these patients that are becoming very, very ill. So next, I kind of wanted to go through testing. And so there are a lot of questions about testing, and I know it's a large kind of point of consternation. And so full disclosure, the sensitivity of the PCR is something that we're still investigating because honestly, we don't have a true gold standard for defining the illness. And so most of the data that we're working with at this point is coming out of China. Full disclosure, a lot of it is not peer reviewed, and there is kind of a lot of observational data that's coming out. But out of a Chinese series of 51 patients looking at chest CT and PCR assays performed within 3 days of the patients presenting with illness, they found that the sensitivity of CT was 98% versus the PCR initially had a sensitivity of 71%. Full disclosure, it seems that the gold standard diagnosis was made by then later positive PCR. So that's something to note. Another study, which was a aggregated population of, and sorry, this is incorrect. It was 1,014, not 10,000 patients, but looking at their nasopharyngeal swabs. And the sensitivity of the PCR ranged from 66 to 80%. And it seems that there were a lot of assumptions made about kind of the gold standard diagnosis. It seems that it was probably a clinical diagnosis that was the gold standard they were using. But once again, not a perfect test. JAMA letter, there were 205 COVID patients, which it seems once again unclear, but it seems that clinical diagnosis was the standard they were using. And as you can see here, that kind of they looked at the PCR in different sites, and BAL had the highest positivity, 93%. Sputum was next, and then the NP swabs were at around 63%. So I really think that this is all probably a function of the fact that NP swabs are honestly hard to do. They're uncomfortable, they're deep. I think that's probably one of the things that we're seeing here as far as kind of limitation of the sensitivity. But bottom line, what kind of the message I want to get to providers is that the sensitivity, unclear at this point, anywhere from maybe 60 to 70, 75%, and really probably affected by technique, and then also honestly probably by timing. We're finding that potentially several days into the presentation that the sensitivity of the test might be a bit higher because we're thinking that patients may be shedding more virus at that point. So there are different factors that go into kind of how sensitive the test might be at a certain point of time. And so I would encourage providers to use clinical judgment. If somebody has what seems like kind of a classic case of COVID, but has a negative PCR, I would treat them as though they are COVID-19, and whether that means they're going home and going on precautions at home, or if they're in the hospital and staying on precautions or getting some sort of supportive treatment, I would highly recommend to use clinical judgment, especially at this time when we're still getting a lot of data on testing. So at Allina, I kind of want to go over what our testing situation is right now, because I know this is kind of a big question that a lot of providers have. And so it's kind of, at this point, we are looking daily at 3 testing sites and really determining who is having the fastest turnaround. So last week we were sending to LabCorp. It seems like there was a bottleneck there. So currently we are seeing kind of a lag in testing in patients who were tested last week. Currently this week it seems that most of our tests are going to Mayo, but like I said, the lab is doing a great job kind of monitoring which of these facilities is turning around tests the fastest. Of what that means for us as providers is what you might see is we send a COVID test, and what lab is having to do is you might see that your order is discontinued, and what they're doing is just kind of reflexing to whatever send out they are sending to. It's nothing that you need to do, but just don't be surprised if you see your original test is discontinued and a new order is placed. That's lab just kind of protocolizing where it's going to go the fastest. And the turnaround time at this point, we're thinking, is probably going to be anywhere from 1 to 5 days, hopefully on the quicker end, kind of more consistently soon. And we're hoping to have in-house testing here at Allina by the end of April. So that is something to look forward to. So in the absence kind of quick turnaround testing, I wanted to go through kind of some labs that might inform clinical trajectories here. And so these slides are courtesy of Dr. Stephen Bradley, who's one of our cardiologists here. And so really what the purpose of kind of going through these labs is to kind of identify patients at high risk of clinical progression and or mortality, and to kind of help us get a sense for, how patients, how their prognosis might go, or how their clinical process might go. And so that can kind of help assist in, I think, goals of care discussions, and really kind of help us kind of put patients in different categories as to where they might go, and potentially, as therapies are coming out, maybe help us determine who might be a good candidate for a certain therapy, and also just really help us anticipate what our system needs are as far as, ventilator needs, ICU staffing, ECMO capacity. So it seems that as far as, figuring out which patients are at risk for ARDS and mortality. So as I kind of alluded to earlier, it seems that the older age group seems to be kind of at higher risk for kind of progressing to ARDS and having a higher mortality rate. Initially, it seems that potentially, having a high fever might portend that these patients might not do well. Kind of like I had spoken about earlier, the comorbidities that kind of can contribute to risk of severe disease, hypertension, cardiovascular disease, COPD, diabetes. And it seems that actually certain labs can kind of help us kind of prognosticate how these patients are going to do. And so I think kind of in line with the theory that patients that do poorly, it's secondary to the cytokine storm, is it seems to be that elevated inflammatory markers can kind of, help us prognosticate D-dimer, ferritin, CRP, and then reduced, actually some labs are on the low side, so lymphocyte count, so lymphopenia can kind of portend kind of poor outcomes. Also, once again, kind of secondary to this kind of hypothesized cytokine storm, secondary HLH. And so it seems that laboratory trends for key markers kind of seem to appear to precede and differentiate other findings of clinical decompensation. And so there are a couple of papers here that kind of looked at patients who are hospitalized with COVID and looking at their lab trends. And so here are kind of links. And so you're able to kind of go and look through these papers. And so it seems that at this point, we probably can't differentiate how a patient is going to do by the timing of their symptoms. And so as you can see, kind of the difference between survivors and non-survivors, there doesn't seem to be a huge difference in kind of their symptom spectrum here. So, potentially we can't necessarily use that, but what we can use potentially is our labs. And so on the left, you can see the non-survivors here are in the red, and then the survivors are in the blue, and this is looking at their D-dimers. And as you can see on the non-survivors, their D-dimers are much higher, and kind of almost, you can see that kind of throughout the course of their illness, there's a larger difference there between the non-survivors. And then on the other side, on the right side, is the lymphocyte count. So once again, we're seeing lymphopenia in the patients who tend to do poorer. So the non-survivors are having lower lymphocyte counts throughout their illness. And so, there is, I would, say that we should, definitely use some caution also in getting these laboratory markers, especially since kind of a lot of these kind of classically in the past we've used for kind of other diagnoses. And so, an elevated D-dimer on these patients doesn't necessarily warrant a thrombosis evaluation in the absence of a clinical suspicion for a thrombosis. And so it does seem to be kind of the earliest differentiator of clinical course. However, just because a D-dimer is elevated doesn't necessarily mean that you need to go down the, thrombosis pathway. And then kind of similar to other markers that are starting to come out that might be elevated in these patients, so troponin and BNP, in the absence of suspicion for ACS or CHF, I probably, would advise at this point against ordering it, even though, it might be useful at some point for COVID patients. There's still a lot of research that's going on, but at this point probably would not order on just COVID patients alone outside of, kind of the classic indications for getting a troponin or BNP. So we do have a COVID-19 order set. And so the labs that are included in that order set at this point are a D-dimer, a CRP, a ferritin, and a CBC with diff. And so as far as our local experience, I just kind of wanted to go back around to our case. And so once again, our patient had no demographic or comorbid risk factors, a seemingly healthy young guy. On admission, had a pretty high fever, had a low lymphocyte count, had a high ferritin, and had a high CRP, which, once again, did kind of predict the fact that despite he only needed 4 liters initially, he did decompensate and did have severe disease with ARDS. So this is kind of, a demonstration of the fact that these labs can potentially be helpful in kind of helping us prognosticate how these patients are going to do. So as far as kind of what that means for us, so, it is kind of an iterative process in defining trajectories and feedbacks. So, what we're suggesting at this point, kind of also based on, your clinical judgment is initially on presentation, we can get these labs and it'll kind of potentially put these patients into low, intermediate, or high risk. So initially, does the patient have any risk factors for progression? Are they elderly? Do they have any of the comorbid conditions that we had talked about? What are their labs looking like? And then potentially, could there be some utility at repeating these labs at 72 hours and kind of seeing how these patients do? I think this is something that we're still working on, but, is something that potentially could be helpful. And so once again, thank you, Dr. Bradley, for these slides. His email is up there, so I think if anybody has any questions, he's really kind of, I would say, the expert in kind of looking at these labs at this point here, and he would be able to address kind of any additional questions here. So next we'll move on to treatment. And so supportive care is really kind of the backbone of treatment for these patients. And so for the patients who do progress to ARDS principles is really important. It is seeming that potentially kind of fluid sparing resuscitation and keeping these patients dry may be important, especially in the setting of them having this kind of massive cytokine storm. Considering early intubation because, it is thought that potentially once these patients are moving on to having really high oxygen requirements, most of these patients progress to intubation anyhow. And so I think there would be kind of a case for intubating these patients early because I think a controlled intubation would be preferred to a non-controlled for the patient's safety, for the safety of the patient themselves, but also for, I think, the safety of our staff here. And then, I think potentially depending on a patient's comorbidities, I think considering, early palliative involvement or at least early goals of care discussion, I think is something that we should really, really think about here. As far as actual pharmacologic treatment for these patients. So there has been no therapy that has been proven to treat COVID-19 in humans. There are a lot of clinical trials that are ongoing at this point, and there is some anecdotal kind of retrospective data from China and Italy on therapies that are available. And then as far as the pharmacologic therapies that are potentially possible, I will say that availability is a concern because everybody in the nation and really across the world is kind of vying for supplies. So full disclosure on that. As far as kind of some suggested therapies that are being currently investigated are, there's a list here. So multiple antivirals and, the thought of whether or not convalescent serum of patients who have recovered from COVID is something that's being investigated right now. The role of immunomodulators, kind of given the fact that we think that there's this, kind of secondary cytokine storm that's happening, is something that's being investigated. Here at Allina, what we have and or are included in our guidelines is hydroxychloroquine, not chloroquine. There's not much availability in the United States, but hydroxychloroquine, remdesivir, which I'll talk about in a second, and then tocilizumab, which is an IL-6 inhibitor. And so there are treatment trials that are ongoing in the United States and in China, and some prophylaxis trials as well. And so this is just I wanted to let people know about the University of Minnesota. They are currently working on a post-exposure prophylaxis trial that is online enrollment based. And so they have that email covid19@umn.edu for patients who qualify. And so it's basically healthcare workers or household contacts with a known exposure within 4 days to a COVID positive 19 person, or anybody who has symptoms less than 4 days and is known to be COVID-19 positive, or a healthcare worker who has been symptomatic less than 4 days and has a known exposure. So if anybody that you know, or if you yourself would qualify and you're interested, there is that email, and they're still, I believe that they're still recruiting participants. So as far as our treatment guidelines, this is kind of an ongoing project. We're trying to kind of fine tune it, and there's discussions every week. The ID task force is meeting every week as new data is coming out, and as our experience is really kind of progressing here. And so, this is kind of subject to change. It is available on the AKN through provider resources. And so basically what we're saying is, you have a suspected COVID-19 patient who comes in, and if they have evidence of a clinical pneumonia, what we are suggesting based on the flow chart is if they are hypoxic, we are recommending contacting ID to consider starting hydroxychloroquine. It is ID and intensivist restricted, or if they're mechanically ventilated, we are potentially looking at initiating the remdesivir process, which I'll talk about in a second, and considering hydroxychloroquine. If a patient does not require supplemental O2, but they are in kind of this high-risk group with a history of lung disease, cardiovascular disease, diabetes, cancer, immunosuppressed, or elderly, and are known PCR positive, we are considering treating that population of patients as well. If you have a patient who is hypoxic or ventilated and you're waiting for a PCR to come back and you have high suspicion for disease, we are considering treating that group of patients too. So this, once again, all kind of subject to change. And here are the therapeutic agents we have. And so I had mentioned remdesivir before. So it is it's an antiviral that has been investigated for Ebola and SARS and MERS in the past. There are a lot of clinical trials that are ongoing. And initially, it was available through compassionate use through Gilead. Currently, they are moving over to expanded access. And so we are applying to become an expanded access site. However, in the past, and this just happened on Sunday. And so we are in the process of setting that up. So what that means is we don't have access to remdesivir likely within the next week or so as we are kind of getting this all set up. I do believe that that there are exceptions for patients that are pregnant, but outside of that, they're not doing compassionate use. It's expanded access, and we are working on becoming a site and being able to offer this drug through ID in the future. But currently, we don't have that. There are certain inclusion and exclusion criteria for remdesivir through Gilead, which is also subject to change. And as of last time I had heard about it, these patients needed to be mechanically ventilated, but couldn't be in multi-organ failure and could not be on pressors and did need a positive PCR. But once again, those might be shifting. So we have remdesivir here, we have the hydroxychloroquine. Once again, these therapies will be restricted to the intensivist and pulmonologist and ID. And then we do have a very limited supply of tocilizumab, which is an IL-6 inhibitor, and there are pretty strict criteria here, and it is, once again, very experimental. One thing that I wanted to go through that was kind of a change within the past couple of days, kind of in response to the fact that our PCRs have been taking multiple days to come back, is a way for us to be able to take patients who are PUIs who we have a low suspicion that they have COVID for out of isolation early as a way to help preserve PPE. And so in the metro hospitals, basically what the process is basically contacting ID. working with the attending MD, the infection preventionist, and nurse manager. And if all of these people agree that the patient has a compelling alternative diagnosis and are have a low suspicion for COVID-19, that we can, as a group come together and say this patient has low risk for having COVID-19, and we can take those patients out of isolation. At regional hospitals, you don't need ID to be part of the discussion, because I know sometimes ID availability out there is limited. And so in that case, it would be the attending MD, the infection preventionists, and the nurse manager. And once again, everybody needs to be in agreement that this patient would be low risk and has a compelling alternative diagnosis. Hopefully this will be a moot point in the next, hopefully, week to weeks, as our testing becomes, our turnaround is hopefully quicker. So I also kind of wanted to talk about COVID-19 transmission. And so at this point, it seems that all data is kind of pointing to the fact that it is really being transmitted via respiratory secretion, so kind of droplet transmission. And so it seems that it's transmitted through respiratory droplets that are excreted in the air that land on surfaces. There's a question for, who exactly is transmitting, because we do know that patients can potentially have a positive PCR who are asymptomatic or who are pre-symptomatic, but it seems that at this point, the suspicion that the contributions of, this type of transmission is probably pretty small. And then, the question is, it seems that most of the transmission, or if not all of the transmission, is droplet mediated and not aerosolized and or airborne. And there have been a few studies that have looked at that. And so we do think that if the virus was transmitted via aerosolization or, airborne from a patient, that we would probably be seeing much different transmission patterns. And it seems there was a study that looked at symptomatic infection and the rate of transmission, and definitely there's a much higher rate in transmission amongst patients' household members rather than casual contacts. And so I think that really does point to the fact that this is all droplet mediated. Also, there was a study that looked at, it was basically just a retrospective look at a patient who had been admitted at a hospital in the United States, who after 3 days of being in the hospital, being intubated and extubated, which are actually pretty aerosolizing procedures, and out of the 41 of the healthcare workers that were in contact with the patient, I think only 6 had been wearing N95s at any given time. 0 of any of the healthcare workers that were working with that patient developed any symptoms of COVID, and 0 had a positive PCR. So I think that data is all encouraging at this point, that this is all truly droplet transmitted. So we've been getting a lot of questions about kind of how we can keep our families safe, right? Because, we all have a lot of anxiety. This is something that's really scary. And what I wanted to point everybody to is the CDC. They have this pretty great clean and disinfect page. And it's really mostly for patients who have suspected or confirmed coronavirus disease. But I thought, it might be a good place for us all to kind of go to kind of just help, give us some guidelines as far as, how we can, best, come home and keep our families safe. But once again, this is for patients, who are PUIs or who have it. So it's pretty, their recommendations, are pretty stringent, but I thought it would be a good place to start if people are asking or wondering. And so, what they're recommending is, avoiding sharing household items if possible, dishes, cups, bedding, cleaning all high-touch surfaces, countertops, doorknobs, bathrooms, as frequently as you can. And then as far as kind of laundering, I would say, when you get home, potentially, removing your clothes. And it seems that actually just washing your clothes just with regular detergent and probably using, the hot setting would be probably best and should, have effect against the virus. So kind of some guidance from the CDC that we can kind of extrapolate out. And then, I kind of wanted to move on to, aerosol generating procedures and, what we consider those to be, because I know that is something that kind of leads into the PPE, which is what I'll talk about next. And so on the left is the WHO guidance as far as what procedures are aerosolizing. And so they think that, so basically things, procedures that have a very high risk of being aerosolizing are intubation, CPR, manual ventilation, bronchoscopy, and then possible aerosol generating procedures that have some risk are BiPAP, oscillating ventilation and nebulization. And so that is, I just kind of wanted to compare that to our list of aerosolizing procedures and just let everybody know that ours is essentially the same as the WHO. Because whether or not staff is providing aerosolizing procedures to the patient is really kind of how we're kind of putting people into groups as far as what kind of PPE they need. And so what we're saying is that for patients who are suspected COVID patients or known COVID patients, when they're not getting any aerosolizing generating procedures, what we're saying is it is droplet, and what we're recommending is basically droplet plus guidelines, which is going to be a mask with a face shield, so we're covering our eyes, and then contact precautions with the gown and gloves. However, in the patients who are getting aerosol generating procedures and or are in the ICU, because those patients, it's, at any moment could very well potentially need an aerosolizing procedure, we are saying that those patients, or sorry, those staff need to be wearing an N95 respirator. Or PAPR or CAPR, excuse me. And so I know PPE is something that there's a lot of anxiety about right now, and I definitely understand it. This is a scary time, and we are doing our absolute best to keep us all protected, while also kind of acknowledging that there is a scarcity nationwide. And so it is, complex kind of decision tree, and there's a lot of things that go into our decision. And so factors that we're considering are, kind of our supply, what our stock is on hand, what our refresh rate is, what our supply chain looks like, what our current usage and burn rate is something that's important. And I think that in combination with kind of the epidemiology and prevalence of disease. And so I think in New York City, Boston, they have a much higher prevalence at this point than we do in Minnesota, but we are looking at modeling for the future and keeping an eye to that. And then also kind of calculating the risk. So kind of what I alluded to earlier as far as, what is aerosolizing, what is the current data as far as what how the virus is transmitted. And then working, kind of across systems, we are, trying to figure out what other systems outside of Allina are doing and kind of working together. And then also, I think it is important to, acknowledge that, we're all nervous and we all want to be protected and we all want to protect ourselves, each other, and our family. And so it is something that we are definitely, there are ongoing discussions. We are meeting every single day, multiple meetings talking about this. And so I kind of wanted to put that out there. And so, given the scarcity, we are kind of moving on to some, reuse procedures that are kind of being implemented across the country. And I just kind of wanted to go through that quickly. And so there is a reuse guide, conservation guide that is on the AKN under PPE. And so what we are basically trying to do is minimize staff, going in and out of PUI and COVID rooms, so that we're burning less PPE, minimizing the use of ancillary support staff. And then as far as kind of reuse, what we are suggesting is, as far as the ear loop droplet masks, respirators, and eye protection, we're trying to encourage use throughout an entire shift unless the integrity is clearly not intact. And then as far as, the eye use protections, the shields, we are able to disinfect those and kind of reuse those until the integrity is not intact. And we're able to reuse the capper shields and PAPR hoods. And then as far as kind of, so I'll kind of go through, each of the types of PPE that we're using. And so as far as the ear loop droplet masks, we do have uninterrupted mask use guidelines. And so what we are recommending is it's okay to use the same mask from patient to patient. We would say that, discard it if it's, obviously soiled, damaged, if there's a hole in it. Don't store these in your pocket. And if you do touch the mask as you're kind of going patient to patient, perform hand hygiene immediately, because the mask could potentially, you could potentially contaminate. And so here are the mask use guidelines, which once again are on the AKN. It's kind of a nice little pictorial. And then as far as the N95s that we're saying that what we're recommending is using a full face shield over the N95 to avoid contaminating it. And we are recommending that we're able to keep these N95s, in a bag, and really only discard it if it's contaminated, damaged, hard to breathe through, or if you feel the integrity is interrupted. Then cappers and pappers can be used kind of room to room and can be kept and disinfected. And then as far as the eye protection, okay to use without, from patient to patient, but, do need to be disinfecting it when visibly soiled or when taking it off. And so once again, this is all on the AKN under our PPE and under the reuse documents. And so a couple of take-home points here. So in the United States, unfortunately, we're on the steep part of the epi curve. In Minnesota, I don't think we're quite there yet, and hopefully, the social distancing and now the stay-at-home order will help kind of, mitigate some new transmissions and hopefully really help us flatten the curve here, but that's kind of yet to be seen. As far as testing is going, I think we're at a point where still tests are taking a long time to turn around. Hopefully that will change soon, but the PCR is kind of an imperfect test, so I think clinical judgment is super important at this point. I think considering prognostic labs, especially in patients who are at high risk for kind of progressing to serious disease. So I think those are something to consider obtaining. Our treatment guidelines are available on the AKN under provider resources, and at this point the treatments are restricted to ID intensivists and pulmonologists. And then as far as kind of our new protocol for discontinuing isolation of low suspicion PUIs, there is a protocol involving at the Metro Hospital is the ID, the attending infection prevention, and the nurse manager. At the regional hospitals, attending IP, nurse manager. Once again, hopefully that's good. This is going to become a moot point as hopefully our tests are turning around quicker, so we know whether or not to take these low risk patients out of isolation quicker. The coronavirus seems to be transmitted via droplets, and so we're in droplet plus precautions for patients who are receiving non-aerosolizing procedures. I wanted to point out the PPE reuse document on the AKN, and then once again, the COVID-19 pandemic is a rapidly evolving situation. There's a lot of research happening. There's a lot of new clinical data that is coming out. So things are really evolving quickly. And so what's true today might not be true next week. So we're hoping to do these weekly webinars to kind of keep everybody abreast of the situation and to any changes. And so we're going to do our best to kind of keep things as up to date as possible. So thank you for everybody, for listening, and I think we're going to move on to Q&A session. It's myself and Dr. Anderson, Dr. Preble here, and so hopefully we'll be able to address some, if not most, of the questions here.
Great, thank you so much, Dr. Lanasa, for that really evidence-based presentation and just really thoughtful way of putting it together. As you can see, we have 45 questions and some more coming in. So we will do our best to get to kind of the highlights, and then we will also do our best to get kind of answers to the ones that we didn't get to and get those out in a link. One that has come up quite a bit with regards to the labs that Dr. Bradley has been kind of working on, and unfortunately he's not here, but he's been texting with me, so I can tell you that for the outpatients right now, that we are not recommending that you get these labs done. that all of this data was in hospitalized patients. So we are not recommending that at this point in time. There may be a time in the future where we can use that, but that we're not there yet. And then he also wanted to emphasize that please, please, please don't get a CTPE study for the D-dimer alone. That I know that that's a little bit of a reflex in the past, but for these patients, we have to take it into context with the severity of their illness. And so that should not trigger a CTPE study. So that's the one that I will address. I'm going to go to the top of the list here. There's one question about what percentage of patients are presenting primarily with GI symptoms in the absence of URI symptoms.
So I think that's not entirely known at this point. I have seen data that suggests that up to 41% of patients who have COVID-19 have GI symptoms. I'm not quite sure what percentage of patients are presenting with only GI symptoms and no other kind of respiratory symptoms. That's a great question, and I'm not quite sure.
Another question was just a clarification. Are 80% of patients asymptomatic or 80% have mild disease?
80% of patients have mild disease.
Okay, thank you. There's some questions about ibuprofen and ACE and ARBs. I'm going to refer you back to Dr. Lanasa's presentation from last week because there's some good data that she presented. So that's just so that we can save on time. That is on the AKN COVID page under provider resources. And then there's a document that's called COVID-19 resources for providers. And then in there's a link to the YouTube video. So I'm going to just
quickly, I can just say that, the WHO came out with a statement saying that there's no evidence for or against use of ibuprofen in these patients, and also the same with ACE inhibitors and ARBs. And I did see that the American Heart Association and American College of Cardiologists recommended continuing those in patients who have been on them prior to admission, who have COVID, in the absence of another reason why you might stop it, like hypotension or AKI. But there's still a lot of investigation going into ACE inhibitors and ARBs.
Lots of questions about CT scanning. And so one question that came up was CT scans, are they positive even in patients with mild disease?
They can be.
Okay.
They can be.
And then the next question about CT is, what is our threshold for ordering a CT chest if there's an indeterminate or somewhat worrisome chest x-ray? That's a good question, and I think patient by patient it's going to be different. I think if somebody has a pretty compelling chest x-ray that shows kind of bilateral, these kind of bilateral infiltrates, you don't necessarily need a CT. If it's a patient who, potentially you're not quite sure, or, if it's really going to change, management at the end of the day, getting a CT isn't incorrect, but, also kind of acknowledging that at the end of the day, we don't want to overload our radiology colleagues. And so it's something that I don't have a great answer for, but, I would suggest if somebody has a chest x-ray that's, pretty compelling and, it's not going to change management, I wouldn't necessarily get a CT. Great. There's a question about adding hydroxychloroquine prior to the test resulting positive.
Yeah, and that's a great question. So on the treatment protocol, what we're saying is for patients who come in and you have high suspicion they have COVID and their PCR is in process and they're hypoxic or ventilated, that, at that point I would pull the trigger and potentially consult ID to see whether or not that patient might qualify for hydroxychloroquine. Otherwise, in patients who are not hypoxic but have kind of some of those risk factors, we're asking that we do wait for the PCR to become positive before potentially starting those patients on hydroxychloroquine. And once again, this document is changing week by week, so we might have a different consensus next week, but yeah, don't necessarily need a positive PCR for the hypoxic or ventilated patients. And also I wanted to kind of mention that we do not have an unlimited supply of hydroxychloroquine. And, we are, it is something that will probably be harder to get. And also, I want to acknowledge that especially, I wouldn't prescribe it for outpatients. the evidence isn't great in the first place, and then we are having a hard time, our lupus patients are having a hard time getting hydroxychloroquine, and that is an absolute FDA approved, indication for hydroxychloroquine. So I think being mindful of that too is important.
Okay. There's a question about the positive rate for Minnesota COVID testing seems very low when one considers we're testing only the highest risk patients. What are your thoughts? Dr. Anderson is here. He can maybe address that too.
Hi, hi. This is Dan Anderson. We really don't know because we don't have good point prevalence data on what the background rate of infection is in the community. A couple days ago, the rate was 4.7% of the tests done in Minnesota. Yesterday it was 2.7%. But again, we don't know what the denominator is. So it's an unknown.
I think you touched on this during your presentation, but we'll just answer one more time. So why do we remove precautions if the initial test is negative but has 30% false negative rate? Shouldn't we repeat the test if highly suspicious?
So I wouldn't necessarily remove precautions on somebody who is a negative COVID-19 PCR who you have high suspicion for disease. Yeah, I would, if I was seeing a patient who had kind of classic COVID symptoms and potentially lab work and their PCR was negative, I would keep them in precautions myself.
Okay. Just want to touch on a couple PPE questions. One about universal masking, and I think Dan has fielded a lot of questions about that, so I would like him to respond to that.
The universal masking question is very complex with many factors. We try to take into account the science of, is that the most protective thing for people? What is the background prevalence in the community? What's the transmission? As well as what we think. Nobody can look into the future, but when is the peak of the epidemic going to appear? How high is it going to be, and how narrow is the peak going to be in time? And in the context of, we don't have an infinite supply of PPE. The one thing we are trying very hard to avoid is being in a situation where, by using PPE now when it isn't necessarily needed, based on the science as far that we have, that we run out of PPE at a time when the peak hits, and then that could present much greater problems. So we're trying to, and emphasizing to people all along, the things that we know are probably the most effective ways to prevent transmission are washing one's hands, not touching the face, social distancing, and staying away when one is symptomatic. Yeah.
Lots of questions about, is this presentation going to be recorded and you're able to be rewatched? Yes, there'll be another link that goes out with the just the same way that you got the invitation. So usually through the medical staff office, there'll be a link to a YouTube site that will have this all, so that if you weren't able to join, you can watch later. The question about sharing it outside of Allina, I think is fine. I might get fired for saying that, as long as they know that these are Allina specific recommendations, so they have to follow their own hospital policies. I wanted to talk, there were a couple about the uninterrupted use. So one about, can you walk around the hospital with this mask on? The answer is yes, that's what we're doing in the ER. And I know that's a little bit different situation, but the Metro ERs are doing uninterrupted use, going from patient to patient with their mask and face shield on, not taking it off in between. I would say on your cohort units as inpatients, that is what we should be doing, going from patient to patient with your mask and face shield on. I think if you're going from one cohort unit to another in the hospital, that also seems reasonable to keep it on. There was a question about the droplet mask and being able to take that, put that back on after you take it off. The official Allina stance right now is still that once it's off your face, you need to throw it away. That might change soon. Oh, and then we're also talking about, looking at your patient census. And so if you know you have a number of patients who need enhanced airborne precautions, so that would necessitate either N95 or CAPR, bunching those together or grouping those together so that you can use that same precaution as you go from room to room. There was one about when are we going to be able to test more in the outpatient setting? And I don't think we have an answer for that. I think when our turnaround time gets better, there is active work going on to try to get an in-house test for Allina, but the earliest time frame that we've heard on that is still end of April.
Yeah, the laboratory directors are working on that daily, if not more frequently, trying to get to the endpoint of an in-house test that has rapid results, and anything in between that and what we have now.
There were questions as well about, do we get early palliative care and DNR orders when the prognostic labs are poor? I think we have to take everything with a grain of salt and put it into the overall clinical situation. There was also a question about some hospital systems making all COVID positive patients automatic DNR. That is not our policy at Allina. There has been a lot of work going into how our code blue teams and our resuscitations will be done on these COVID positive or PUI patients, but that is not Allina's policy. We'll just do a few more. Now we're up to 80 questions. One about the respiratory viral panel and its utility. I'm going to let the infectious disease doctors field that.
I mean, that's kind of a difficult question. We're still not quite sure, what, the, incidence of patients having kind of dual infections is. I've seen it, mentioned anywhere from, 5% to 22%. I think for certain patients who are in the hospital who, are PUIs, but you have low suspicion that they're COVID, and you get a respiratory viral panel and it turns out they have human metapneumovirus, that might potentially, help you be able to take them out of isolation, quicker. I think, there would be utility to the fact that, influenza is on there. And if somebody is flu positive, I mean, we've got a medicine for that, we've got relatively good evidence for, and that's Tamiflu. So, I do think at least getting a flu in these patients is useful, because if they have the flu, you can do something about it. Could they have COVID at the same time? Potentially. But it's still kind of to be determined, kind of case by case basis, I would say.
Okay. We'll do two more questions here. One was about that were some patients whose tests were drawn, on the 20th or 21st, and they're still waiting for labs. And then we had patients admitted yesterday who already have their labs back. So yes, we are aware of that. At a system level, they were calling inpatient providers who had patients who had tests from the 20th of March or earlier to get new orders to reorder a lab test so that we could send it to a different site. I have not heard any updates as if now we're saying from the 21st or not, but so more to come on that, but the 20th was the official date. And then the other question, which I think is a really important one, is that reuse of PPE from a PUI room to a known COVID room. And I'm going to let the infectious disease doctors speak to that. The question is, can you use the same PPE, like uninterrupted, going from a known COVID room to a PUI room to another known COVID room, or do we need to separate known COVID positives from PUIs?
No, I think especially in the COVID cohort units, one can use continuously the face mask and the eye shield. One has to take off the gown and gloves when exiting a room, But as long as one doesn't touch the face mask or the eye gear and they're not visibly contaminated or falling apart or whatever, then one can go from room to room, from PUI to confirmed. Because at this point, if a person's a PUI and they turn out to have COVID, that's no different than a known COVID to a PUI.
Great. All right, I think we will end it here. Thank you so much for all of you guys for participating and asking such great questions. There was a lot of questions about, are we going to get a transcript with the questions? So yes, we will try to answer as many as we can and get them out to you. And then this recording link will also be sent out. So we will plan on doing this the same way next week. And thank you so much to Dr. Lanasa and Dr. Anderson for putting these slides together and being here to answer these questions live. It's really an important part of our education of our physicians.